Good afternoon, dear colleagues. Today we will tell about diabetes mellitus in children and adolescents. And we will start our lecture with definition of diabetes. It is very important to understand that diabetes is not a single disease. It's a group of disorders united by one main sign, the disturbances of the carbohydrate metabolism. These problems with the carbohydrate metabolism leads another metabolic problems and finally we can see the severe chronic complications of diabetes like dysfunction and failure of different organs and systems. Classification by the etiology includes first of all two types of diabetes, type 1 and type 2. Type 1 diabetes usually appear when we've got an autoimmune inflammation of the pancreas, of the islet cells, of the beta cells. In most cases, it's an immune-based reaction and we can see it in most patients. But in some patients, it is non-immune-based disorder. Type 2 diabetes, of course, it should be the first in this list because the most patient worldwide is the patient with a diabetes type 2. It may be in patient with obesity and without obesity. And you learned this type well last year in your endocrinology class, so I will not tell you about type 2 diabetes today. Other specific types of diabetes usually depends on genetic disorders, and we will tell about them a couple of words. Disease of exocrine pancreas like pancreonecrosis and chronic pancreatitis may lead to diabetes too. Endocrine diseases. At the first place, of course, is Cushing disease and somatotropinoma and thyrotoxicosis will affect the carbohydrate metabolism too. Please note that some medication can lead to diabetes in case of long-term or overdose using in patient. So be aware about these disorders and check the glucose level in patient with this treatment. Infections can lead to diabetes too. Sometimes very rare, we can see the immune-mediated diabetes, but very uncommon forms like a Stiffman syndrome or anti-insulin receptor antibodies disease. And last one is gestational diabetes. The incidence of different type of diabetes very different, and you can see the most cases it's a type 2 diabetes, about 75%. About 10% it's a type 1 diabetes, 10% gestational diabetes, and only 5% all another cases, but it can be. Other specific types includes MODY diabetes. What means MODY? It's a maturity onset diabetes in youth. Neonatal diabetes, two forms, transient and permanent, and mitochondrial DNA diabetes. Maturity onset diabetes in young includes several forms, and you see some list with type 1, type 2, MODY 2, MODY 3, MODY 4. These numbers just means the time of the diagnostic of this diabetes. In pediatric population, we can see some MODY type diabetes, but quite rare. Remember about these types in case of the very mild cause of disease of diabetes in young patients with a family history of diabetes type 2. Neonatal diabetes. We will tell about neonatal diabetes in case of the diagnosis in first 6 months of life, and this is a rare disorder. We can see different types of neonatal diabetes due to different gene defects. So it leads to different treatments from the diet to insulin therapy. And note, two forms of this diabetes needs a sulfonylurea preparation. It's very rare cases when we use this type of drugs in patients younger than 18 years. The algorithm of diagnosis of neonatal diabetes we can see in this slide, and you can use it in your future work. Gestational diabetes. Gestational diabetes usually appear during the pregnancy, and it disappears when the women give the birth of child. But for the first glance, it's not very dangerous because it just disappears by themselves. But we can see the severest complication in fetus, and you see the gestational diabetes is not rare condition. So in all the countries now we use the screening for gestational diabetes for pregnant women. What can we see in newborn with from mothers with gestational diabetes? We can see several symptoms. It's different and severe congenital abnormalities and some problems with metabolism. Due to chronic hyperglycemia in fetal blood during the pregnancy, we can see first of all macrosomia. It's a really huge newborns. The weight is over 5, sometimes 5 and 5, 5 and 7, 6 kilos. These newborns have got, unfortunately, immaturity lungs and some breast problems. It's like a respiratory distress. The patient have got a severe hypoglycemia. Due to this, in the previous century, most of them just die. So it is very severe complication, and we should treat gestational diabetes like a diabetes type 1. And we will tell about type 1 diabetes because it's most common problem in the pediatric population. The incidence and prevalence of type 1 diabetes is different in different territories, in different countries, and we can see the rising incidence of this disease in developed country. You can see this some countries, and the leader, of course, it's Finland. Finnish people have got a specific genotype which leads most often diabetes type 1. The diabetes type 1 are diagnosed in different age with different rate. So the most often we can see this diabetes in preschool children from 5 up to 15 years. The peak about 12 years. And in adults, it's just comparable with preschool children. What about this incidence in your countries? Unfortunately, in India, the doctors had not the register of diabetic patient, and you can see this very nice article in the Indian Pediatrics by yourself. It's absolutely free, and you can see that you have got a low diagnostic of this disease in pediatric patients. About Iraq, unfortunately, I found only one article about Basra, and they study the incidence of diabetes in patients younger than 40 years. So you can see it by yourself too. And about another country, unfortunately, another Arabic country, only Saudi Arabia and Kuwait and some Morocco and Algeria, of course, have got some studies result about incidence for patients younger than 20 years. So it's very difficult to know how is the incidence of diabetes in Arabic country now take place. So, definition. What means diabetes type 1? It's autoimmune disorders, usually appears in children and young adults, which leads the injury of the beta cells. And we can see the most cases autoimmune, and type 1b, it's a non-immune diabetes type 1. It depends of genotype, and to make some prognosis we have to know the uh, types of diabetes, the relatives with type 1 diabetes in family of patient, and protective gene and risk gene combination in this patient. And our colleagues genetics now can do it and make a very good consultation for our patient's family. The diabetes type 1 have got a different stages. The first stage is the genetic predisposition, and during this stage we can't see any clinical symptoms. More than, due to trigger contact with trigger, firstly we can't see any clinical signs too. We start to see the symptoms of diabetes only in case of 75-85 beta cells death. So we became to see the symptomatic diabetes mellitus. What is the triggers of diabetes? First of all, of course, it's viral infection. It's most important trigger. And in this list, at the first place should be enteroviruses, Coxsackie virus, mumps, cytomegalovirus, and rubella very dangerous for fetus and leads the neonatal diabetes. Environmental factors, of course, can play some role in initiation of diabetes, and diet. And of course, we have to remember about early formula or not formula or cows and goats milk feeding of babies younger than 1 year. It is extremely dangerous for the autoimmunity. So please remember um, about the breastfeeding, how it's valuable for the future health of your young patient. Migration processes usually increase level of diabetes and different beta cells toxins. It's a different things around us, like a petrol, like a pesticides, like leads, and a lot of the environmental beta toxins. What's happened in the immune system? Now, our researchers found different way of the injury of our immune system in case of type 1 diabetes. It's some defects in bone marrow and thymus, which leads some problems with T lymphocytes and B lymphocytes. In immune system, it's some dysregulation, some unequal numbers of T helper and T suppressor, T effectors and T regulation cells. And of course, some problems with B cell, which can produce a lot of autoimmune antibodies. So we can see the result of these processes in the beta cells and the pancreas of patient with type 1 diabetes. And we can see some damaging due to autoimmune autoantibodies affection and cell affections. What's happened inside the body in case of the diabetes mellitus? It's not depends of type of diabetes. Because it's the first place, it's insulin deficiency. It can be absolute insulin deficiency or another insulin deficiency. So, for example, receptors insufficiency. So what can we see? we can see the energy deficiency. We can see the low intake of glucose to the hepatocytes, to the liver cells. And I think everybody remember that we've got three insulin-dependent tissue in our body. It's the liver cells, muscle cells, and adipocytes. So, in case of low intake of glucose, the insulin hormones, and I have to remember you that all the hormones in our body are contrainsular, but most it's glucocorticoids, it's catecholamines, and somatostatin. So we can see activation of these hormones. It means that the gluconeogenesis start to activate. To make this efficient, we need some substrates for gluconeogenesis. It's proteins and lipids. So the contrainsular hormones activate the lipolysis and proteolysis, and we can see the end products of this process, some free fatty acids, and amino acids, and they can't be used for building another structures of lipids or proteins, and that means that we can see higher level of free fatty acids, higher level of intermediate product of their outbreak. This is ketones or keto acids, and the free fatty acids start to oxidate, and we can see the beta oxidation. This process can kill cells, and ketoacidosis and ketonuria. Due to proteolysis and due to increasing level of the amino acid, we can see increasing of the urea and uric acids, and this can decrease the pH level inside the blood. Glucose, urea, free fatty acid increase the osmolarity of the blood, and this osmolarity, hyperosmolarity, leads the some transport of water from the cells and intracellular spaces, and we can see increased level of the circulation blood volume. Of course, it increases filtration, and hyperosmolarity of urine leads to some dehydration due to water loss. In case of severe dehydration, in case of endotoxicity of some intermediate and end product of the proteolysis and lipolysis, the brain neurocytes start to suffer, and we can see the coma and death. What can we see in patients with diabetes mellitus? We can see the different types of clinical presentation. Classical symptoms of hyperglycemia, symptoms of diabetic ketoacidosis, some accidental diagnosis due some well-taken visit, and we can see the anorexia nervosa-like symptoms when patients start avoid the food, they prefer only liquid, and we can see the severe weight loss and dehydration. At the beginning, we can see the non-emergency presentation. We are talking about the preschool children, school-age children, but not about the children younger than 5 years. In this group, we can see some episodes of enuresis, night enuresis, in toilet-trained child. We can see some candidiasis, perianal region candidiasis, especially in prepubertal girls. Chronic weight loss or failure to gain weight in growing child in good appetite. irritability and decrease in school performance, and recurrent skin infection like a purulent skin infection. Emergency presentation. It's first of all signs of dehydration, moderate or severe dehydration. It may be nausea and vomiting. In the first stages, it's just a couple of vomitings, and then it's frequent vomitings. Abdominal pain, and when we can see the combination of the vomiting, nausea, sometimes mild fever and abdominal pain, of course we can presume and misdiagnose some abdominal problems like gastroenteritis or appendicitis. This polyuria, increase in polyuria and dehydration. It may be weight loss, and we can feel the acetone smell in the breath and sometimes in urine. It's acetone smell. It's not like a chemical acetone. It's like a fruit smell, unfresh fruit smell. And in patients with severe ketoacidosis, we can see the paleness of the skin, but cheek looks flushed, very hyperemic cheeks. And then we can see some neurological disorders like disorientation, like weakness, like a lethargic or comatose situation. And in case of severe dehydration toxicity, we can see the shock-like symptoms. It's symptoms of shock, of course, unhydrated shock, like increased pulse rate, low blood pressure, and low peripheral circulation. And in this case, of course, it's a very dangerous condition. We should treat patient immediately. What diagnostic difficulties can we meet in case of the diabetic patient, pediatric patient? Very young children, younger than 2 years, may present in severe ketoacidosis very fast, and we can see some signs of severe dehydration like a severe fever and frequent vomiting, and we can misdiagnose some infection. Sometimes we can see meningeal signs in this group of patients. In case of abdominal syndrome, we can misdiagnose appendicitis, I told you about it, and polyuria, especially in the initial stage, we can mix with some urinary tract infection. Polydipsia may look like a psychogenic polydipsia, and vomiting, of course, in case of adult children, it's infectional gastroenteritis, and in small children, it's sepsis. So be aware about the diagnosis of diabetes. What should we do? How can we confirm our suggestion about the diabetes? Of course, we should check the blood glucose level, and we know that the blood glucose level more than 11 millimole per liter or 200 milligrams per deciliter. It's a diagnostic level of glucose or blood glucose. A modified oral glucose tolerance test, when we check the glucose in fasting situation and after the meal in children, not the glucose after the meal, which contains the carbohydrates, we will use only in case of asymptomatic patient with the hyperglycemia, mild hyperglycemia. Remember that acute infection, especially the infection of CNS, may mask the diabetes in one hand. In other hand, this patient can have the hyperglycemia, moderate hyperglycemia without diabetes, and we never can see the ketoacidosis. Better to use a glycated or glycated hemoglobin, and level of this hemoglobin more than 6.5% usually means that we've got a diabetic patient. To confirm the type 1 diabetes, we have to check the antibodies, autoimmune markers. We can see the different type of antibodies: islet cells, cytoplasmic autoantibodies, insulin antibodies, glutamic acid decarboxylase autoantibodies, tyrosine phosphatase autoantibodies, and zinc transporter 8 antibodies. Usually we use the GADA antibodies and EA2 antibodies and zinc transporter 8 antibodies. Usually we ask ourselves, can we cure diabetes? Can we treat diabetes? Because it's chronic disorders and we can't very good treat the autoimmune diabetes. And we usually answer, of course we should. Next question, should we cure diabetes? Should. How can we cure diabetes? We can cure diabetes, and we've got some goals of our treatment. First of all, we have to prevent death and elevate symptoms. We have to achieve a good glycemic or biochemical or metabolic control. We should, in case of pediatric patient, not an adult, we should maintain growth and development. And of course, in all ages, we have to prevent acute and chronic or late onset complications. Which complications we can find in patients with diabetes? First of all, it's acute decay, diabetic ketoacidosis, and hypoglycemia. Late onset, it's retinopathy, nephropathy, neuropathy, and in adult persons, in teenagers, it may be ischemic heart disease and stroke. What's treatment elements now we have to treat the diabetes? First of all, it should be education. Education for patient family and patient. Of course, in case of type 1 diabetes, it's insulin therapy. Diet and planning of physical and meal planning and planning of physical exercises. And our patient should monitor level of glucose, blood glucose, the level of ketones, and we have to monitor the glycated hemoglobin. To manage of diabetes, we need not only pediatrician or pediatric endocrinologist. It should be team of specialists, includes educators, it's usually nurse, dietitian, pediatric podiatrists, pharmacologists, and different other specialties like neurologists, surgeons, and of course it's physical therapeutics. Glycemic target for the patient with type diabetes, it's hemoglobin, glycated hemoglobin less than 7.5%. There are fasting blood glucose 4 to 8, it depends of age. In young children, we have to use a more higher level of fasting glucose level and more higher level of postprandial glucose. 5 to 10 it's for all patients, but for younger it's maybe 8, 10. And be aware about hypoglycemic episode, because hypoglycemia is very dangerous for immature brain. We should, and I told you, in children younger than 6 years, we have to minimize hypoglycemic episode. Education. Education should include some topics about what means diabetes, what is a disease, why we should use insulin, what type of insulin should use patient, and we should explain it for patients and parents because the compliance of therapy will depend of our education. It's vitally important for patients to recognize the hypoglycemic hyperglycemic or ketoacidosis episodes. It's very important to plan meals and plan the insulin therapy, and of course they should know what should they do in case of another illness like infection, for example, viral infection. What's insulin we usually use for treatment of patients type 1 diabetes? It's of course human insulins. It's prandial insulin or bolus. We usually use short-acting insulins, and now we use insulin analogs. And we use basal insulins. It may be intermediate acting insulins or long acting basal insulin analogs. In our republic, in Russia, in most cases we use a combination of the rapid action insulin analogs like Novrapid, insulin aspart, glulizine, Lispro, and combination with the long-acting basal insulin like Detamir and Glardin. Why we use this combination? Because it's most physiological and can make the good replacement therapy in our patient. And we should think about several situations: child's age, duration of diabetes, family lifestyle, social economic status of family and their ability to buy a different type of insulins, and of course we have to remember about patients or family preferences. Insulin therapy, usually we use more than 2, in Russia usually 3 daily bolus injection of rapid acting insulin and 1 injection of basal insulin like Glardin. And you can see it looks like a normal insulin secretion. You can see here normal insulin secretion, and there we can see how can we mimic this insulin secretion in our patient. Children with new onset diabetes usually started off on boluses of rapid action insulin, and then we should see what can happen. Maybe child will need another scheme of insulin therapy due to their, for example, study. And we can use a different type of insulin delivery. We can use just special insulin injectors, and we can use now an insulin pump, and in Western countries it's a bionic pancreas. In our practical classes we will discuss about this regimen and these types. What about dosage? Of course, it's usually individual, but you can use this table, this scheme in your initial work, and you can see in patient with young age, we should use a small dose of insulin. And remember about the honeymoon. What means honeymoon? Due to staging of the type 1 diabetes, after we start our treatment, there are beta cells which still alive. It's about maybe 15, maybe 10, maybe 20%, usually start to work and to produce the insulin. So our dose of our insulin therapy will be decreased due to hypoglycemia. We have to monitor this situation, but never stop the insulin therapy. You can use 1 unit of insulin, but use till continued, because it's psychological, very important for patient. they have to understand that they will use the insulin all their life. Diet regulation. We have to use the carbohydrates. We never avoid the carbohydrate from the patient diet, but we should count the carbohydrates amount in patient diet. And we have to use the proper insulin therapy due to this diet. Patients have got the same energy intake like their healthy patient at the same age. Exercise, physical activity is very important for patients with diabetes, and we should use the checking of blood glucose before and during exercises, and just add some carbohydrate contains meal. Self-monitoring of glucose patient need it quite often, and due to last guidelines, it shouldn't be less than 4 times a day. In case of some another disease, for example infection, patient can and should make the glucose checking maybe every 2 hours, more often, and during the night too. And this is the end of my lecture. Thank you for your attention.